see me and see everything clear, please say yes, or just write a message on the messenger. Yeah, I don't know if I cut. So you can see everything, yeah? Oh. Okay. So I'm going to start, yeah? So it will be, first of all, I think we have 9 or 10 participants in this talk. My name is Dr. Naji بركات. I'm consultant pediatrician neurologist in the UK. I've been in the UK for 30 years now, consultant for about 21 years. My interest is doing neurology, but I chose this subject is to talk about the recognized sick children, because it's very, very important. What we're going to do for the next, hopefully, 3 talks, today, tomorrow, after tomorrow, talking about the this emergency in pediatric neurology. So first thing is about sick children in general, then tomorrow about status epilepticus, and hopefully on Wednesday we will talk about the febrile convulsions. And after that I will take you through the neurology, maybe the week after or the week before that, after that. So it will be, I promise to give 10 lectures in pediatric neurology, excluding this one. If there is a problem or you can't see or anything, please messenger me, because I didn't set up the Zoom as to listen to hear you. So I think it's, let's go do the next one, yeah? So that's the, you still see it, yeah? Okay, so the objective of this talk is recognizing sick child, apply skills to manage these patients or children, and not to miss all signs. It's important when you see someone in casualty or on the ward or in the neonatal units, there's a certain things you need to follow up to recognize if this child is sick or not sick. The reason for we saying you recognize them very sick, it's to catch them in the compensatory phase. If you catch them in a compensatory phase, then the survival, it can go up to 90%. But if you miss it and they go in the uncompensatory phase, which is a failure, then the survival rate is less than 30%. So it's important that you catch them up in this. The next one is, why might people missing the signs? Why? Because a lot of people is they have experience, they have everything, they have skill, they have the knowledge, but it can be missed. So it could be the least thing is a lack of knowledge or experience, because I know all of you went through medical schools and graduated, and some of you working and experience if you work. Or is still a student, so you have a knowledge, and sometimes the experiences comes over all the time. So that's why people missing this sign is because the lack of experience sometimes, mostly not following best practice and guidelines. So best practice, that is mean you have like an algorithm. If you done a course which is advanced pediatric life support or basic life support, then I'm sure you've been taught about ABSD. That's the best practice is always through the guidelines. Usually because early sign of many illnesses are similar, especially in pediatric. The fever, not eating, not well, pale. So they are different, but there's other signs you need to look for them as well. Poor communication. Sometimes this poor communication is the worst thing between the teams, because sometimes if you don't communicate effectively between you and other colleague or other senior doctors, then this can be also missed. tiredness and lack of sleep. These days, some people they work 24 hours, 48 hours or more, and they can't make a good judgment, and they will miss these signs, and there will be a lot of consequences for that. Okay, now, so the assessment. What is the assessment need to be done? The assessment is when you go. We know as a medical student, because most of you are medical students, is looking for the history. The history is very important. Even a short history for 2-3 minutes or 1 minute from mother or the fathers, it is important. Direct questions: what's happening? What's going on? What is, if there's any other symptom, rashes, color response, respiratory rate, heart rate, rash, skin, eyes, and then after that, this is how when you do the assessment, you take a history, you do the assessment, then the examination, then investigation, then management. I'm not going to do investigation and management today, but I'm just going to take the first 3 topics. So the assessment is, this is a broad spectrum assessment with the airway. It's patent or not patent. It's in good position. There's a vomit, there's a something. Breathing, is it regular, not regular? Labile, cardiovascular. We should talk about it all in detail. Disability, neurology, exposure, everything, illnesses. So maybe they have been exposed to, they've been in contact with someone who's having meningitis, neisseria meningitis, or viruses or other conditions. Fluid, renal, but they have done. Did they vomit? There's they have a wet nappy, or they pass a urine, or they have diarrhea or vomiting. Gastro, yes, as we said, hematology may or may not be required at that stage, and infections and rashes as well. So this is the assessment. This is put it in your mind: A, B, C, D, E, and then F, G, H, I. If you put all of these and you look to all of them, and that it may take you a minute or 2, then obviously you will recognize if the patient is sick or not sick, and that from there you can take it forward. So this is the what we call is a triangle assessment, and you can see if there's any you can see appearance, work of breathing, circulation of the skin. I'm just typing something, so it's not to worry. So appearance, abnormal tone, interactiveness, consciability, abnormal look or gaze, abnormal speech, cry. This is the appearance. So the moment you look to them, you need to these 5 things to look. Then work of breathing is abnormal sound, making like stridor, wheeze. Is it expiratory, inspiratory? Because inspiratory is a wheeze, and inspiratory is the stridor, and expiratory is a wheeze. Retraction, that means subcostal or intercostal or tracheal tag. Flaring, that means the nasal opening is just, especially under the age of 1 year, is very easy to use. Sometimes when it's very bad, even the older ones. Apnea or gasping, that's the final stage. Then the circulations, pallor, mottling, cyanosis. So you need to all of them. And I put a link there if you want to use. There's a very, very extensive discussions about this triangle of the assessment. Okay, so now how to assess common symptom in sick children or sick child. This is difficult. How to assess them? Difficulty in breathing, fever, rash, fits, dehydrations, abdominal pain, head injury. I just put the link there. This is from the Royal College of Paediatric and Childhood. They have very, very nice course, which you can do it online. And it is very good. And you would be, it would be complementary to this talk, and you will find it very helpful for you if you want. And hopefully the organizers, they put this talk on their website, so you can look to it again and looking to this as well. If you missed anything. Now we will go through the system per system. So how to recognize a potential respiratory failures. So this is 6 things which you need to consider them. The first thing is respiratory rate. You know, respiratory rate is different from age 1 year, from 1 month, or 1 day till 18. So like someone who is a month old and he's breathing between 35 and 40 is okay. That's could be, it's be normal. From 1 to 2, if it is 30 to 35, it's still okay. But if they are exceeding 50, 60, 70, it is not okay. And someone who is 11 or 12 and breathing 30, 35 is not okay. So that's what you need to think. Recessions, you know, the diaphragm, as where is the insertion of the diaphragm is 5, 6, 7 keep you alive. Yeah. So so that's mean the diaphragm is, they're working very hard and pulling, and that's, you can see the rib movement as well. And that is inspiratory or expiratory noises. We said inspiratory, this is usually stridors, upper airway obstructions, and expiratory, which is wheeze, which is lower airway obstructions. So you need to do that. And grunting, that is mean grunting because entering that means breathing against closed epiglottis. So that means the grunting. That is mean final stages. Accessory muscle use as well in the chest, and flare of Allen-Azai, which is very evident under the age of 1 year. So you can see the chest X-rays, he's both of them, and this is very severe chest infection, which is usually viral stage. So common causes of hypoxic respiratory failure, that means the lack of oxygens. When they have a lack of oxygen, either they have a chronic disease or pneumonia, but you can see the list is there in front of you. There's a lot, all of them can lead to hypoxia. And if the hypoxia happened, then it is the, if you don't treat it quickly, then it's one of the commonest cause of the killer in pediatric patient is hypoxia. Is it primary or is it secondary? So if it's primary due to obstructions or secondary due to the lung disease or heart disease or brain disease or sepsis. So hypoxia, so that's why you can see when you go to the A&E, oxygen emergencies, the patient the moment walk to the A&E with breathing fast or having problem difficulty, they give them oxygen. Hypoxia is the most common killer because the brain cannot survive more than 3 minutes without oxygen. So that's why every time you see someone who's breathing, who's using all his muscle, making noises, tired, put the oxygen mask on them. And that's, and of course, I'm not going to in details on this, but I will leave it with the organizer to share it with you, because this blood gas interpretations, it is one of the commonest that may help you to decide whether this is respiratory acidosis or metabolic acidosis or respiratory alkalosis or metabolic alkalosis or mixed. And someone who is working in intensive care or who work in accident and emergency, they will know this much better. But I think as a general pediatrician or someone who's in training or medical student, I think you need to only the 4 top one, which is it will help you to understand the physiology of blood gas. As I said, the blood gas results is this is algorithms which is really tell you about the base axis, and you can see if the base axis is -6 to 2, no compensations, and just hypovolemia it could be. If the base axis -2 to -3, it could be respiratory in shock, and the same thing is the others. So you need to look at carefully. Anything base axis is more than -6. That is mean is the child is really passing the compensatory phase and may entering the uncompensatory phase, which at that stage you need to act very quickly and do something. So common type 2, which is hypercapnia, that is mean is the CO2 is very high, which is mean there is a chronic condition there. But sometimes a chronic condition will be getting worse with acute respiratory failure as well. So that's why brief history to ask about any diseases in the past that will help you to decide whether this is a chronic, acute on a chronic, or just a chronic or acute. So if you can't, then if you are dealing with the patient, then ask someone else to go and talk to the parents and tell them what is going on and what is medication he's on or she's on. And that's, I mean, brief history will help you as well at that stage. But the most important thing in the respiratory failure, as I said, is airways. Make sure it is clear, patent, and nothing in it. And then the breathing patterns. And for both of these, you need to put, if there is a potential failure, you need to go and put oxygen on the baby and make sure the airway is open. And then, as I said, is if you have an experience or have done advanced life support or basic life support, then you know how to open the airways, and also to look for the breathing, and also listen to the chest if you have a chance to listen to it straight away. So that is the respiratory failure, which is which is the commonest cause of the deaths in the in children if it's not recognized and done something quickly about it. The airways and the breathing. This is the most important. So you need to act very quickly. The second one, which is either a primary or secondary circulatory failure. If it's primary, it could be related to the loss of volume with the blood or urine or fluids, or it could be secondary due to heart problems or sepsis or circulatory failures or CNS failures. So that's the circulatory failure. So the four things which you need to always think about when you do recognizing to assess is the heart rate. The heart rate is different. So up to 1 year is 140 to 150 is okay. But if it's to 200 or more, this is not okay. But someone who's 11, 12, and his heart rate is 120 or 130, it's not okay. You have to do something because the first thing our body responds when there is a sense of dangers because of loss of volume or sepsis or anything is entering the compensatory phase. And the compensatory phase is the heart rate go fast. And so that means pumping a lot of blood to the body, to the organs, so to compensatory phase. So that's in that stage you need to recognize them. If the heart rate starts dropping in front of you, well, it was 120, 130, and dropping started quickly. That means uncompensatory phase. The child's going to arrest any minute. Then the pulse volume. Pulse volume, you can check the radial. Under the age of 1 year, you can do the brachial. If above 1 year, you can do the radial. You can do the femoral. But older ones, teenagers, you can do even the from the neck. And the pulse volume tell you if the volume is low or not palpable, that means you are reaching a shocking state. The capillary refill is the other one, which is you can do it. You have to do it centrally. A lot of people, they holding the index finger or any finger and then count. No, do it centrally. And centrally, which is that's mean pressing on the sternum and count 1, 2, 3, or 1 elephant or 2 elephant, 3 elephant, 4 elephant, 5 elephant, and then lift your finger and count back. Normally, it should be below 2 seconds. 3 seconds is okay, but if it's 4 or 5 seconds centrally, it's really bad circulation. Blood pressure. Blood pressure at the beginning will be high, especially the diastolic. But if the blood pressure starts going down fast, that is mean you are the child is getting to the shocking state and entering uncompensatory phase. So make sure is someone do the blood pressure while you are. So this is the 4 criteria for recognizing potential circulatory failure. So we're just going to the CNS failures. The neurological assessment has 4 key components. You have the conscious level, AVAPU, alert, respond to voice, respond to pain, unresponsive, or postures, or pupils. And the other thing is glucose estimation. Make sure the sugar is done straight away. Because if someone who's unconscious, you do the sugar, because sometimes they are hypoglycemic or hyperglycemic. And that is very important because you can reverse it very quickly. The conscious level is AVAPU. This is the easiest way to do it. But if you know the Glasgow Coma scale, which is 15 scores, then do it. But it is a longer procedure. But this is a quick alert, respond to voice, respond to pain, and responsive. If alert, fine, leave them alone. You don't need to do anything much, just carry on. Respond to voice, that is mean they are semi-conscious, so they protect airway. If there's space slightly, then at that stage you need to make sure the airway is patent and they are breathing on their own, because they may not protect their airway. Unresponsive, of course, they can't protect airways, and you have to do something with the airways at that stage. Posturing, I will talk to you either the Decorticate or Decorticate, which I'll show you some slides. And pupils. Pupils are equally reacting or not equally reacted, dilated, unilateral, bilateral. They will give you a clue, as I said, the glucose. So that's the postures in someone respiratory failure. So the Decorticate posture, in which the child is rigid with the flexed arms, so in the chest. So everything is flexed, and clenching fist and extending the legs. So the legs is extended, and the arm is fixed around the neck, which is motor response of 3. So this means Glasgow Coma scale is below 3, and this is airway. You need to do something and protect them. And this is all indicate there is increase in the cranial pressure, whether there's a bleed, whether there is edema, there is trauma. So this is a herniation of the brain. One is decerebrate, which is the opposite of decerebrate, is indicate even more serious damage. Both arms and legs are rigid, and they are in extended positions. And this is a Glasgow Coma 2 or 3. And this is increase in cranial pressure, and make sure is you assist them. So next, we're talking about because I'm just going now to talk about a few topics about the what things which causing the this sick children, or they are very bad. So shock is a complex clinical syndrome. I'm sure you read about it, and you and in your physiology in particular, as a response to cellular metabolic deficiency, mild agitation. So when some they're mild agitated, what will heart rate, because this is the compensatory phase, the heart rate will be and then cold peripheral skin with decreased capillary retain. So that's mean cold peripherally as well. So someone who's been shocked is this is how it starts. So the cellular perfusion is reduced, and that is mean. So that's mean the body, or the everything is going to the main organ, the heart and the brain and the kidneys, and this is where the everything is going there. But from this you will find out whether this is a compensatory or non-compensatory phase. So if they're becoming agitated, skin pallor, increased heart rate, they are in compensatory phase. So you make sure you do something at that stage. So here is a compensatory, what is a compensatory phase and uncompensatory phase. So you can see the compensatory phase is agitation or confusion. So you need to give oxygen, skin pillars, that means circulation is bad, you need to put fluid, increase heart rate, you make sure when you give fluid and oxygen to come down, and blood pressure may be high, diastolic affected more than systolic at the beginning. Don't be fooled that is blood pressure is okay, you keep measure it. So someone need to measure it, like I would say every 5 to 10 minutes need to be measured, because unless you are happy, if you have it 5, 6 reading is normal and the heart rates come down and the skin is much better, then you don't need to carry on. Cold peripheries, yes, make sure you warm them, cover them, don't let them exposed, because it helps quite a lot. Decreased capillary refill, as I said, this is centrally, and this is indicated circulatory failure. And you can see between the compensatory and uncompensatory in these two photos, the child on the here, normal, good color, everything is bright looking. The one down there, the one is in the bottom, is really shocked. And probably they have done a lot of treatment, and he's in a bad state. So uncompensatory phase is falling blood pressures, very slow, very 3 or 4 seconds centrally, cold peripherally, acidosis breathing. Sometimes they have you can smell it, or especially in DKA, or depressed cerebral status, mean they're not responding to pain or voice, or unresponsive. And also sometimes there is no urine if you put a catheter in that. So, and then irreversible, which is if you do something in compensatory phase and you recognize them, then the survival rate, as I said, 90 or more than recognize them and they slip to the uncompensatory, then the survival 30%, and they will have a lot of bad outcomes. And if you don't recognize the compensatory phase and you did done nothing, and the child will be dead. And remember, they have a prolonged compensatory phase. So that means they give you time. They take enough time to help them. And then when they enter the uncompensatory phase, enter it very quickly, and they slip to a reversible stage very quickly. While the adult, they have a very short compensatory phase as well, and a very short uncompensatory phase as well. So the children, they have a longer compensatory phase, more than this. So that's why we said recognizing sick children in the compensatory phase, it is your gold standard. It is your objective all the time. When you walk to the A&E, to the ward, to the neonatal unit, this is your objective. You want to make sure you recognize the child is not very sick and you do something about it. Now, the causes of the shocks is hypovolemic shock, there is distributive shock, there is a cardiogenic shock, there is obstructive shock, there is dissociative shock. The hypovolemic, loss of volume from anywhere. And distributive, that means the heart is not good enough. And the main cause of distributive is the like the anaphylactic shock or cardiac failures. And it's a cardiogenic shock, which is the heart failure cause. Obstructive, with the same thing is being the fluid, it is not going back to all the bodies. And one thing is sometimes a pneumothorax or hemothorax or anything. And the dissociative, that means the distribution of the fluid in the body, it is not very well organized, whether there's a CNS failure or sometimes the anaphylactic shock. So these 5 types of the shock is it is what you need to find out when you assess the child or a shocked child, to find what type of them, and then accordingly you could manage them according to the cause of the to the shock. And the volume one is loss of volume is dehydrations, and dehydration is one of the commonest cause of loss of volume. And I think it's about 10 million every year they die from gastroenteritis related to dehydrations worldwide. And your task is always to recognize where these children they are mild, moderate, or severe. And if they majority of the time by the time to reach you in a hospital, usually severe ones. The mild parents, they will not bring them. The moderate, they may bring a few of them. But the severe ones, they reach you, especially if the parents live far away or they don't have a way of to the hospital, or there's some issues in the around the hospital, in the place, a war or curfew, or today's is coronavirus and this thing. So they always reach you in a severe state, and you need to recognize them: tachycardic, pale, capillary-filled, shocked. Everything is in compensatory phase, and the most important thing is an oxygen to give to them at this stage. So the hydration is one of the things is following the gastroenteritis mainly, or vomiting, or sometimes even you know, the commonest other things is diabetic ketoacidosis or anaphylactic shock. All of these because lack of fluid. Yeah. As I said, there's the two children who's having severe dehydration by the time they reach you, the top ones, and you can see when they are treated how they are changed in the appearance. So the bottom two photos is normal after they being resuscitated and given a fluid and treated accordingly. The top one, when they came to you in a hospital in a bad state, so can recognize them and treat them accordingly. The most common killer in a pediatric age group these days is a sepsis, typically neonate, especially under the age of 1 year as well. Neonate under the age of 1 month and under the age of a year. And so that's where is one thing is start maybe simple thing with a bit of temperatures or vomiting or diarrhea, and then they will explode very quickly in front of your eyes. So you need to do something. Early septic shock compensated, raise cardiac output, warm extremities. Yeah, they are warm because they have temperatures as well. Wide pulse pressure, mental confusion because of hypoxia. So you need think about that. So so make sure you recognize them in that stage, because the survival is really 78%. But if you don't recognize them late compensatory phase, then the 80%, and they can very so you become the main killers in a children's or as a result of many things. So if you want to be good in your practice and you be a good doctors and everything, please go read about the sepsis. There's a lot of things coming in the last 2 to 3 years, and they have a very, very good recognized them, and specifically the nurses who triage these children. If you teach the nurses how to triage the patients, and specifically for sepsis, then definitely you will be achieving your goals. So nurses can play a big, major roles in recognizing the sepsis in children when they do very good triage. And that's why I'm saying go and search and read about sepsis. If you don't know where to go, just go to the Royal College of Paediatric and Childhood in UK website, and they have really very good package and course for you to learn how to recognize children who is having sepsis or neonate as such. Just a few photos, and you can see the top one is here. If you can see, this one is this is typical of what we call it purpura, just bleeding under the skin, and sometimes you feel it, and when you press on it, it doesn't disappear. And the same thing is a lot of petechial rashes here. Don't be fooled if you see a lot of them. Make sure, shouldn't have a lumbar puncture. It's contraindication here. And here the worst disease, if you come, which is the meningococcal septicemia or the meningitis sepsis. Luckily, now we have two vaccines for meningitis, Neisseria meningitis C and B. I don't know in Libya yet to have the vaccine for B, and hopefully they should have it very sooner to stop this disease from causing death in children as well as teenagers, which the commonest causing Neisseria meningitis type B. And you can see here, you don't want to recognize the children in this stage. You need to recognize them when they come to here, like 1 or 2 spots, 10, 5, 6 spots. And the most important thing is educate parents to recognize this type of rashes. If you educate them, then they will recognize it, then they will bring the children to early stages, not in this stage when they have a lot of morbidity. If they survive, they will have a lot of morbidity. They may lose limbs. They will have other issues as well. So make sure you are familiar with now the seizures. The seizures in next 10 lectures. I'm just in the compensatory phase here in the recognizing the children. So when they came in status epilepticus, that means the seizure more than 15 minutes or 30 minutes. So they have a raised cardiac output, feel warm, blood pressure normal or high, unconscious. Remember, children, they all the status, they are unconscious. So to make sure the airway is patent, oxygen, and then put them in a recovery phase. And then if you don't stop the seizures, they enter in 30 minutes, then they enter the uncompensatory phase, which is pulmonary edema, which can kill them, and hyperthermia as well, cardiac dysrhythmia. They will have a lot of the problem with related to the drug if you give it wrong, hypertension, cerebral edema, because the muscle is broke, they will have myoglobin in the urine, and then at the end stage they will have a lot of these chemicals, lactate and others, which is poisons to the body and causing intravascular, disseminated intravascular coagulations, and at the end stage. So that's why children who, or adults even, they shouldn't be let fit more than 30 minutes. If they reach 30 minutes and they don't stop, then you need to anesthetize them, intubate them, and ventilate. We will talk about it in tomorrow in managing the status epilepticus in more details. So pain in children. Remember, when you are dealing with children or with any patient, either conscious or unconscious, they feel the pain. So make sure you handle them properly. Make sure you explain to them if they are alert. Make sure you think about giving them analgesia if it's not being given. If they are being intubated and ventilated, you don't need to worry. But if they are alert, and make sure they need in pain. So use local anesthetic cream for any local procedures. Doesn't matter. If you have no cream, use the spray. I don't know if you have it or not. Make sure, just make it humane for them, because that is and give analgesia when it is needed. And remember that we don't do PR children at all in my life, and I hopefully you don't do it as well. So remember, I just want to. We have another. I will just carry on talking. I will have another maybe 7 minutes to talk. Then and hopefully the organizers or they can let me see if you have any questions. Please start writing them down, and then I will answer them one by one if it's possible. Early warning scores, and I left the it is published in BMJ, and you can look to it. And this is an early warning score are generally defined as bedside triac and triggers. So you it will talk about all what I said, and also in more details. If you want to read about it, do it. And then I'll advise you, if you are really enthusiastic and very active and a very organized person, to do like a sheet or point, and show them to the nurses, show them to the other your colleague, and put them in A&E, because work together. Because this is, if all of us start recognizing sick children or even adults and prevent them from going to uncompensatory phase, then a lot of patient will be survive and you will be satisfied. And also to educate parents about doctor. So you can do two charts, one for the parents, one for the doctors. And tools help to alert staff to clinically deteriorating child by periodic observation of physiological parameters, generations of numeric scores, and predetermined criteria for escalating urgent assistance with a clear framework for communication. If you take this statement and break it to 5 or 6 categories: periodic observation, physiological parameters, that's mean heart rate, respiratory rate, and pulse oximeter, blood pressure, generation of a numeric score. If you can put scores. If you read this paper, they will give you scores, and predetermined criteria for escalating it. And then you said, well, if the score is 10, you don't need to do anything. If the score is 3 or 5, then you need to escalate it and getting help from a senior colleague to help you. So this is like a flow chart. If you draw it between and do it in your A&E, that would be great. And this paper will help you quite a lot. And maybe let me know at the end of my 10 talks what you have done. Have you achieved this? This is like a small exercise for you. I would like each of you to go and draw a flow chart, and then you may send it to me through my email, and then I will comment on it and send it back. This is like a small exercise for you to do if you want. Just another case. Ahmed is a 2 months old baby, coughing for 2 hours, off feeds, and crying more than usual. Any cause of concern? I just want to, between you and yourself, are you concerned? If you're concerned, what is your concern here? I'll give you pause for 10 seconds, and then. So your concern is he's 2 months old, he's coughing for 24 hours, actually, not 2 hours. The most important, he's off feeds. Baby, the most thing they like, babies, is feed. If they are off the feeds, that means something serious. So this is the message you can tell parents or mothers. You said, if your baby off feeds, it does mean there's something serious. Either he's in pain, he's sick, he can't breathe, he's in heart failure, blah, 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 so amazing. And crying more than unusual. So crying, that is mean he's in pain, he cannot breathe, he's having. Now, I just want you to say, is he sick or not sick? Okay. Just a tiny exercise. So we're just reaching the end of the talk. This is a rapid assessment for an infant or a child. So when you do your chart, you can do airway and breathing, AB. I didn't include it. So this is when you go for APLS course or advanced life support course, then that's it. That's the ABCD. So airway and breathing, wall breathing, respiratory rate, rhythm, stride or wheeze, auscultation, skin colors, and airways. Is it patent or not? Is it open or not? And then what you can do, if it is open, you just, if they respond to you, call their name, and they said, yeah, yes, yeah, oh yeah, yeah. And if they don't, then just put your cheeks on their nose or their mouth, and then lift the chin a little bit up. So that means open the airway and listen if there is a breathing or not. If there is no breathing, then of course you give 5 breath and then ask for help and blah, 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 the scenario will carry on. I'm sure if you haven't done basic life support or advanced life support, this is how they teach you, A, B, C, D. And then circulations, then breathing, of course, work of breathing and respiratory rate and any noises or anything. Don't put your finger inside their mouth and try to dislodge any foreign body. I think the best thing is to hold them and then do like maneuvers or slap their back or anything, whatever. Circulation, heart rate, pulse volume, capillary, and then I should include blood pressure here, skin temperature as well. So blood pressure is very important here. Disability, evabo, posture, pupils, and don't forget the glucose. So that's the end of my talk, and hopefully we get to the we reach our objective. Back to the beginning of the talk, and I just want to, as I said, my objective is apply skills to manage these patients. So your skill to manage this patient is to give them oxygen, fluid, ask for help if you need it, and not to miss all signs. So remember not to miss what we have to. And I will leave this slide of you. Okay, so we finish, and if there is any questions, I'm quite happy to okay.